Vincent to ask questions.
Yeah, sure. Link.
I'll get the link. Just give me a sec. And I'll
Yep.
send it to you.
Okay.
There you go.
Yep.
And I'll put that into the event as well.
Yep. Stream is muted on my end. Okay, it says how many watching now. Top chat. I should have live chat so I can see everything, right?
Yeah.
Okay, live chat. Opt out chat. Chat. Facebook. Thing. You did put it on the Facebook event, right? The link?
Yeah, I'm putting it now.
Sure.
Yeah, I've just put it.
Okay. Here we go.
I suspect it's working. But we'll see.
41 sponsors. Now, 42 said they're going. Okay, let me just pop out participants. Just you and me at the moment. Hang on, 3 watching now. Who's the other person? 2 watching now. Okay.
I had a really bad on-call 2 nights ago.
What happened?
I got called in at 5:30. I got home at 5:30 p.m. Yeah, that's how fried I am. Can't even tell. And then got home at 3:30. Then was up at like 6:30. For a full day list.
Oh.
Yeah, it wasn't fun.
No.
I don't expect people to be on early. Everyone's busy.
Yeah. So what are the plans after this? You said like a journal club kind of thingy?
Yeah, that's what I wanted to do. Some journal club style thing would be nice for people who are properly interested. So we can discuss like work that they're doing, how it can be improved, stuff like that. But it's really to like also an opportunity to help like guide people, get people like interacting on research if they want to, and basically like bounce ideas off each other.
For watching now. Hang on, where do I see? Well, participants already shows you on at the moment.
Well, not everyone's logged in probably.
Okay, so they have to log in to do live chat stuff.
Probably. I don't know how it
Live
works.
watching now.
Yeah, I don't actually know how it works. I
Okay.
just I just assume it does.
Okay.
Technology these days is pretty good.
Yeah. I just keep watching those numbers.
Hmm.
Just
But yeah, I was pretty tired by the end of it.
yeah. I'll just put a message in the chat.
Mhm.
Okay, we've got one response.
Very good. Hi Jane.
Yeah, this is the annoying thing about not doing Zoom because they can't really respond
Yeah,
with
well,
voice. If you type
Zoom would be nice if there wasn't so many people interested, and also like
it. Yeah.
Zoom's like very temperamental when it comes to uh, hosting large groups. Sometimes
Yeah.
like they limit it to 40 minutes and whatnot. I was
Yeah.
also considering doing Microsoft Teams because I've got university access on that, and I'm sure it
Yeah.
works. But
Yeah.
that was also like I don't know how technology works, so
hmm
I just do what I have to do.
hmm
Did I tell you how my weekend on call started?
Weekend on call.
Yeah, I
No.
was on call last weekend, and so Friday night I went in just to see like a leg because that's what my job
hmm
is, and
hmm
then as I'm about to leave, like I've signed out, get a call, we've got a gunshot.
Ooh.
I'm like, I'm not Liverpool anymore, where it's like routine, but like yeah, no, it was a good case. It was a good case.
Mhm. Hmm.
So yeah, I think I'll just start smack on
7:30.
7:30, regardless of who's on or not. Um,
Yeah.
but yeah. Oh, Typhoon is on. I know Typhoon. Typhoon might be able to relate. I was just telling Vincent, who's also on, about how on Friday, my Friday weekend on call started with a gunshot wound, and all I could think is like, I'm not at Liverpool anymore. I left that place.
There are emojis for YouTube live chat. Hmm.
There's emojis for everything.
Yeah.
Pretty sure you can. Surely you can put emojis into medical records by now. They surely implemented that. You know, you can put diagrams in now. It's
Oh.
really good. Like, um, it has this like pop up window, um, like paint, old school paint, and you got to like draw it with your mouse. And
Oh no.
yeah, it's
Probably make
great.
a probably make a gallery out of EMR art.
Yeah, it's no, it's really useful because when we do like aortic stents, we have to well, it's easier to draw it than describe it in text because
Yeah.
no one can understand it.
Yeah.
Um, yeah, but it's so cumbersome because you're like there with some like terrible mouse that's been used for the last 10 years,
Oh.
and the mouse pad has just disintegrated underneath you, You're trying to draw some Mona Lisa thing so ICU understands what you've done. So I interestingly just had the quiz for biostats.
Mm-hmm.
Went really well. It was like um, an enjoyable quiz.
Like
It
this is
was
the final
yeah,
exam
yeah,
or a different
the
one?
final.
Okay, right.
It was like kind of, you know, made you think a little bit, but wasn't overly challenging. So it was a bit
Mm-hmm.
like a puzzle,
Yeah.
which I liked. Not many people say they can enjoy a quiz, but I actually
Mm,
surprisingly enjoyed this one.
mm,
Maybe because I felt like I was getting things right, which is pretty rare.
yeah. 20 on right now with 4 minutes to go. Seems all right.
Yeah. I'm pretty sure there's like a good like latency. So some of the interactive parts might be a little bit slow. That's
Yeah,
all
that's
right.
fair
We
enough.
we have time. Um, Probably like 30-second latency.
Mm, okay.
So when was it that you find out about your PhD result?
Mm. So from when the reviewers get the manuscript,
Mm-hmm.
which would have been sometime in the last 2 weeks, I'm not sure how long it takes on that end. They
Mm.
have 6 weeks to mark it and like send their results.
Oh my, that's
I
pretty
mean
fast.
but that's the procedure. Like
Mm.
if the reviewers are a bit slow, then it's just that the research school will prod them a bit.
Ah, okay. So it's probably going to be longer.
Yeah, and then like this stuff has to turn around. So
Yeah.
let's
When
see.
when I um when I was asked by like some oncology journal to review a paper, they gave me 2 days turnaround time.
Wait, what?
Yeah, 2 days.
And you're not even in wait, why is an oncology
Oh, surgical
you know
oncology.
oh, okay, right, right.
Yeah, yeah. I don't care about actual oncology. Surgical oncology is actually somewhat interesting.
Okay.
So I
If
don't know what
you
they
watch
expected me to do in 2 days.
hmm, you watching 2 minutes ago. Wait, if you're wait, are you a staff engineer or just a student? I'm just gonna think.
In what? In what?
For like you said you had uni.
Oh, that's when I was an examiner for UNSW for the
Oh, okay.
final year exams, like for the OSCEs and stuff. That's when
Ah,
they
okay.
gave me access to
Staff.
Microsoft Teams.
Ah, okay.
Yeah,
Do you
but
have other
like I have alumni
okay, yeah, yeah.
access, but I don't think that's to Teams.
Okay.
It's only for
I,
the.
I'm just
Um,
wondering if you would have perks like Zoom access, like a Zoom. You can get
nah,
Zoom.
I didn't look at it too deeply, but I don't think there's many perks that were
Okay, fair
around.
enough.
Um,
Yeah. just looking at the numbers now, it looks like we could have potentially fit this on Zoom, but we couldn't have
It's not
possibly
worth.
planned for
It's not
this
worth. It's not worth the. Not worth it.
effort. Yeah, fair enough.
Zoom would melt down. Someone would keep their microphone on. Their dog would go crazy,
Well,
and then yeah.
that's what the mod's supposed to do, like stop that, like mute people
You
and
reckon you could control 100 delinquent cameras on Zoom?
it's just like if 30's manageable. You just scroll through 2 3 pages of cameras, mute everyone or mute everyone on entry, do
Yeah,
things like that.
that would be fun
Okay.
for you.
Um,
I'll start in a little bit, Vinny.
yeah, I'll remind people of chat.
Mm-hmm.
Sure if they can scroll up, but
You never know.
yeah. We'll jump to 38.
No, I didn't even see that. Yeah, I'll start in the next 2 or 3 minutes. All right, Vincent, I might just get started then.
Yep, that's fine.
So my name's Erin Saricilar. I am a vascular surgery registrar at Royal North Shore Hospital, ex-UNSW alumni. And I've got with me Vincent Chiu, who has just come off the back of submitting his PhD thesis on hepatocellular carcinoma. He'll be moderating the comments a little bit, helping out with some of the questions and assisting me when I inevitably get lost in some of the biostatistics, which is always a bit challenging. I've also got Darth Vader here, who will be controlling the comments as well, if anyone runs rampant and says anything inappropriate. So yeah, this will be Medical Research 101. Very concise but in-depth look at medical research. It's one of my interests in surgery and medicine overall, and I think it's very important for growth as a doctor to be able to understand medical research thoroughly. So to start off with, let's start with a case. Mr. VG. Now this is something that I see relatively often in our emergency department, so I'll go with this. So he's a 67-year-old man who's just presented with 6 hours of tearing chest pain that's radiating to the back. Some of the older medical students might already be able to tell you what's going on here. A CT aortogram shows a significant dissection from the left subclavian artery origin to the celiac artery origin. In resus, he's managed thoroughly with anti-impulse therapy and appropriate analgesia, and he's transferred to ICU and similarly managed. He's all stable from a blood pressure and heart rate point of view. Past medical history is pretty unremarkable. He's got hypercholesterolemia and mild hypertension, both moderately managed with medications. The diagnosis is of an uncomplicated Stanford type B aortic dissection. Now, these are very, very challenging medical conditions and surgical conditions, and there's no thorough guideline on how to manage these. So this is a great topic to try and start you thinking. So the question I had and still have, is when should we intervene, and should we even intervene surgically? Should we be placing thoracic endovascular graft? And if we are, should we place it in the acute period, so less than 2 weeks since onset of symptoms, or in the subacute period, which is more than 2 weeks? And is it a better option than open treatment or just medical treatment? These are all questions that are often asked. And so this is just a little bit of a thought to put into your heads as we'll go through some of the steps in research using this story. So in your own mind, and it'll be good if you write this down for yourselves, think of a patient where you weren't sure about the best approach to management. The person on the right is meant to be Mr. VG. It may in fact be you after you think about biostatistics or medical research, but let's go with Mr. VG. Try and make the question relatively niche, so don't make it incredibly open. So you can make it open, but don't say, for instance, what is the rate of DVT in people on the oral contraceptive pill? Or this is too heavily researched, well understood, and so it won't be that pertinent to medical research for you guys, particularly juniors. It's good for higher level research units, but for individuals who just want to start getting into research and publishing, you don't want to go too broad. So what I'll be going through is medical research and what it is, the stages in various research projects, formulating questions, doing systematic reviews and meta-analyses, narrative reviews, primary studies, how to construct them, what they are, and finally a pretty bullet pointy explanation of biostats, which everyone misses out on at uni. In fact, usually doesn't even listen while at uni. During this, people should ask questions in the chat. Vincent will be there, and I can also see it, and try and respond to some of the questions, so I'm not just stuck there by myself staring at a busy screen. So what is medical research? Medicine, well, Western medicine itself is based on evidence-based practice. So in decision making, you need to go to an evidence base, look at what is out there to support or justify your decisions, and then you go about treating or managing or even referring patients down certain pathways. So some fields, it can be very challenging to find evidence. So an example is this Stanford type B dissection that I set out for Mr. VG. There's very little evidence, and in fact a lot of the evidence is conflicting. The more niche you go into a topic, the more challenging it is to find higher level evidences. You can complete research at any level. You can be an intern, you can be a consultant, you can be a retired consultant, you can not even be in medicine, and you can do research. And it can be quite an enjoyable experience as you both learn and contribute to the community. And the best part is, personally, what I like is for that split second before someone else publishes something more, you are technically an expert in your field, and you should know absolutely everything there is when it comes to answering your research question. And people will base decisions on what you've done, if you've done it well. Another thing that I like to think is with a strong evidence base, you're able to sort of take the burden of decision making off yourself. When you're conflicted about a patient, you can refer to what other people have found to be the best way, and you can feel more comforted, and you can explain to the patient that this is the safest way with the current level of evidence. Also, if you don't do medical research or you don't understand medical research, you technically can't adequately consent a patient for things such as surgery or even a change of medications. You need to have an understanding of it to be able to do that safely. Now, there's different levels of evidence. The levels of evidence I like to use is the Oxford classification of evidence. It goes from 1 to 5. 4 and 5 are not particularly good levels. On the right here, you can see the table, and the highest level of evidence there is a conglomeration of a lot of studies, which is a systematic review. That's where various parts of different studies are put together and then evaluated as a whole. An individual RCT, which is very well done with very tight confidence intervals, which I'll explain, is also classified very high. Systematic reviews that don't use RCTs are in the category of 2, and other things such as cohort studies, which can also be a type of RCT, are also in the category of 2. When you're putting together poorer or lower level studies as a systematic review, that is in the category of 3, and case control studies, etc., are also in that area. Going on a little bit further than that, when all of this is synthesized together, such as on systems such as UpToDate, it is even higher of a level. You can see here the syntheses on the left and the synopses kind of put information put together from a lot of different sources and evaluated independently. There's this new concept of computerized systems that is meant to be the top of the top, which is the implementation of electronic signals to tell you what you can and can't do. Currently in Australia on EMR, for instance, if you're charting too much of an opioid, it will give you a warning, and that's an example of these systems. They're considered the highest level of evidence. So when in research, there's different stages. So the first stage is identifying a problem, which is what we've done, and you can do that yourself, and you should write this down so you can start thinking about it. Then you should perform a literature review. I recommend you do it as a systematic review at first, which I'll explain, and as a narrative review. The reason you do this is so your systematic review won't often be able to answer your niche question, but you'll be able to answer a question that's pretty close to niche. The narrative review is then designed to help you conglomerate a lot of sources and answer the missing niche in a less systematic fashion. In fact, create a pathway for primary study, often requiring a pilot itself. Once you've done the primary study, that's when you can start creating a randomized controlled trial. Formulating questions is very straightforward, and you should use a PCOS system. So I'm sure a lot of you have learnt about this, but it's great to hammer in. P is population. I think you should keep this moderately focused. Don't keep it too niche, but don't make it too broad either. If it's too broad and you're capturing everyone, is a problem. So just quickly, someone's asked, what is a narrative review? So a narrative review is where you, as a researcher, put together a lot of different sources, but you don't have a systematic method to doing it. I'll go through it in more detail, but in a narrative review, it'll be you just Googling things that you think are relevant. So if I was going to do it for the type E dissection there, I would go to Google Scholar and search timing of type E dissection. And I'd just take the top 3 things, read them, and then write a review about it. A systematic review, on the other hand, I will create this question using the PCOS format and go to a database to then troll through everything that is there. So it's reproducible. A narrative review isn't. If that hasn't answered the question, just please tell me. But coming back to the formulating questions, the intervention needs to be incredibly focused. So this is what you're targeting. Population, relatively broad. So if I was to create, we'll go into it, but if we were going to go a bit more detailed with my question, we'll discuss how focused to keep it. Control or comparator isn't always necessary. So a lot of systematic reviews don't actually need to target a comparator, but it's good to have it there, and it doesn't always need to be a control. Outcomes keep that really broad. That's my suggestion, depending on the systematic review, obviously, but generally keep it very broad. So if you are looking at surgical outcomes, don't always specifically look at the 30-day mortality, unless this is exactly what you want to answer. Try to keep it broad. Look at the 1-year mortality, or in distal stents, the stenosis time and things like that. Finally, study type. It's a bit challenging when you're looking at niche topics, because there might not be that much out there. You might not be able to find all of the there might not even be any randomized controlled trials to include, and you're just left with case controls. So I usually keep that one empty. But moving on, this is a chance for you guys. So what would you put for P, population, for Mr. VG? So he was a 68-year-old gentleman, from memory, who's come in with a type B aortic dissection. What would be your population question? Just answer in the chat if you can. If you don't, in the next 30 seconds, I'll make it up myself. Okay, there's some good answers so far. Adam has said humans, whilst potentially tongue-in-cheek could be valid. A lot of studies are animal studies, and you do want to narrow it down to humans. Males above 50, very good also, but what you want to be targeting is a type B aortic dissection. So Dilnor with type B aortic dissection in males over 60 of cardiovascular risk factors, very good. I like that one a lot. I think it might be a little bit too narrowed, because a lot of studies won't target people with cardiovascular risk factors, and a lot of people at that age already have cardiovascular risk factors. But I think I like the ones looking at males or age with aortic dissection, type B specifically. So whoever said males above 50 with aortic dissection, not quite right. You want to be type B. Also, gender. You don't always want to include gender unless you believe that's going to be a confounding variable. Let's look at intervention now. This one has to be very niche, and this will be challenging. So the question I asked was, what time should you intervene with a TEVAR, which is a thoracic endovascular aortic repair? That was a question I wanted answered. What would be your intervention? Okay, Hayden, it's good with the idea time to TEVAR, but you can't do a comparison with time to TEVAR. If you can, in a systematic review, just have intervention as time to TEVAR, but you're going to miss out on the C, the comparator part. I see no issue in saying time to TEVAR, but I would more specifically target early intervention. Adam, also good with surgery or no surgery. So remember, with intervention, you only want one thing that needs answering. So Jane, very good with TEVAR in less than 2 weeks. That is a question I want answering. Typhon, perfect. So Rohan as well, with late TEVAR versus medical management, those we will put into the comparator, because our question is for early intervention. Now, this sort of comes down to me knowing what the management is and the typical management is and how that goes ahead. But when you start being more tailored to your specialty, you'll start being able to answer these a bit easier as well. Finally, outcomes. This one is a bit challenging, and you sort of need to have done a few of these to know, so I'll skip into that myself. So these are the answers that I had. So the population I want is specifically uncomplicated Stanford type B aortic dissections. I excluded doing a search for age because I want to capture everything. If you wanted to answer your patient exactly, you would include age and you would include gender, but you would find you might get 0 sources as a consequence. My intervention is TIVA in the acute period, and my comparator is TIVA in the subacute period, open surgery, and medical management. So I want a comparison of each of these. My outcomes were aorta-related events, survival, and quality of life. Now, I didn't specify timing in any of these because remember, you want to keep your outcomes as broad as possible. Finally, study type, not necessary, topics too niche. If we could do randomized controlled trials on this, I don't know how that would get past the ethics board, but we'll get to that later. So systematic reviews themselves usually need 3 people. The reason is because when you're reviewing sources, you need 2 people independently reviewing the sources and 1 person to deliberate any issues that come up. So they need to be completely independent. Everything that is done in a systematic review needs to be performed a priori. So that means you come up with a methods and then you apply those methods without changing them during the course of the study. It's nearly the same as a randomized control trial. You have the methods which you stick to. You can also register this on sources such as Prospero, which is great. It means that people can look at whether or not your systematic review has changed since you started. You create a search strategy, like the questions we created there. You consolidate all of your findings, you summarize these, and that you can create a table to summarize. You perform an analysis, such as a meta-analysis if required, and then you discuss this and explain it relating to your research question. What people don't realize is that systematic reviews are basically primary studies, but you're just not doing it in a lab. In fact, when I was doing my master's of surgery, the dissertation, I found the criteria for what you could do was either an independent primary study or a systematic review. I don't see the value in just doing a systematic review, but that's for UCID to decide themselves. The most important thing is that every step has to be reproducible. So this is a study I did some time ago. This was as part of my master's, and this was a search strategy I used. As you can see here, there's no comparator because I wanted to stay as broad as possible. There's population, intervention, and outcome. So my question was, what tools can be used to assess endovascular surgical competence? So my population were trainees, medical education, vascular surgery procedures specifically. My intervention was competence or assessment of clinical competence. And then my outcomes were quality control, competence, job performance, and a barrage of other things. Now, these I then put together in with or and statements. Down the column with population or whatever it is, you typically want to go or. You want to capture everything that fits into there. Across these columns, you want to go and. You want population and intervention and outcomes. I then ran these in Medline, Embase, and Cochrane. So these are the three key databases you want to be searching on. If you're going to do any, it should be Medline. Cochrane really only captures randomized control trials. Embase has a slightly weaker base when it comes to the quality of the journals that are included. But you should include all three and you'll get a lot of overlap in these. Then you just do totals. I like to include all of the numbers there in order to increase reproducibility, and people can compare what's done. When you've done this, you need to put this into Ovid. Now, Ovid is a minefield, and it's a big challenge to even log into. But most institutions have a login. I know UNSW has a login, and I know UCED has a login because I've used it for both of them. It's relatively intuitive. You just need to capture the database you're using. You just need to click change just above where your search bar is, and then you just click the check boxes in order to and or statements. So someone's asking if UNSW still offers Medline. Maybe Vincent, you can answer that if possible, because you're more recently at UNSW, but you shouldn't be searching for Medline in the UNSW library. You should be searching for it in Ovid. Moving on, you need to do a source review. So the way I like to do it is there's different software you can use. I currently use EndNote, but I've used a variety of others. You just import everything. Now, after you've imported it, you should create a series of groups. One is being all, the next is title exclusion, and the final being abstract exclusion. The beauty of these tools is that you're able to get rid of duplicates very quickly. You can also do searches for PDFs. I personally like using PDFs. I don't like using the websites. And I import nearly all the PDFs into EndNote, so I'm actively able to see the abstract right there and review the whole article right there. Finally, when that's all done, you put it all into one group, and this is what you work with. So some people are saying that UNSW doesn't have Medline anymore. I guess then you'll just need to figure out how to do the search in PubMed. But Medline is your ideal. If you can include Embase and Cochrane, that's also really good. Cochrane will already be included in Medline, but the reason I like to do it is so I can separately see what randomized control trials have actually been performed. It's just easier, and you can include it there as a number as well. So anyway, coming back to it, EndNote is great for this. You create this final conglomerate. After you've done the EndNote, you need to create a table. This is a table that I use in most of my papers, nearly always table 3, interestingly. It's a description of included studies with quantitative data with level 1 to 3 evidence based on the Oxford levels of evidence, which is cited. I just like to put down the authors, study type, the year it was done, if there's any funding, a population, sample size, intervention, outcome, statistics. The one I've put here actually isn't completed because I haven't included the level of evidence and I haven't actually summarized the statistics properly. But it's this is just simply how I summarize everything that I'm reading and I see. It helps later on, particularly as you can move things around into subgroups and I like to then copy and paste the statistics and findings into the body of the document as I'm writing, so it's just much faster. Now, Prisma is something that was set out by the Equator Network in an effort to improve reproducibility in systematic reviews. So rather, you've got 4 sections. You've got identification, screening, eligibility, and included. So at the top, you just include the numbers for everything that's in there. Then a total number of records. Everything that is a duplicate you take out, and then you're left with the records after duplication. Duplicates are removed. You can then exclude by title and abstract. And I actually usually have a table that summarizes the things I'm looking for as inclusion and exclusion criteria. And then you're left with full text articles assessed for eligibility. You can then exclude these at different points. So for instance, non-English is often an issue. Sometimes you'll find just opinion pieces, and they usually need exclusion. I'll occasionally exclude things if I see intense bias. So for instance, if they were funded purely by a medical company or sponsored by it. And then finally, I'm left with studies to include. You want to get this relatively low. If you've got studies included of more than 80, for what your purposes, is probably a bit too much. Vincent can tell you that for his literature review, he had something like 500 sources. I don't believe him, but he says it's true. Finally, this is really important in a systematic review, is to include contributors. So this is for a review. It's still in the works. Actually, I think this is actually to answer that type B dissection question. Everyone needs to be have at least one tick in research, manuscript approval, accountability, and other. So if you don't have at least one tick in those, you shouldn't technically be included as a researcher or be included as a author. Sorry, you can be included in the acknowledgements. That's not an issue. The writer is usually very simple. So I have a template. This is a template I use for all of my papers. Now, this is, I've sometimes wondered whether or not this pops up in Turnitin or whatever study they do. But it's just spaces that need to be filled. As you can see here, there's a section on PICOS. There's there should be, all of the sources I use, the databases I used, and then an explanation of each of how things were assessed, and if a meta-analysis was performed, how it was performed. And then there's sections for results and discussion and conclusion. If people do want these templates, I'm not that willing to give out my template, but I can work individually with people to create these templates. The reason is because I don't want my template ending up in every journal possible, and then I get in trouble. The final result looks really nice, and you can be really proud of what's done right at the end. And they usually make it up really nice for you, and unfortunately they don't give you a free copy. I like actually illegally, you didn't hear that from me, illegally downloaded that copy. You can also do presentations like posters like this, and they are some of the systematic reviews are often the higher requested, higher level requested presentations at conferences. Now, meta-analyses. These are challenging. So what a meta-analysis does in a systematic review is you're putting together as much of the data in various studies that you find and comparing them. So if 3 or 4 studies are looking at the same question, you can put them together and create a systematic review and a meta-analysis. That's one of the best studies that you can perform. The things you need for that is you need things that estimate the effect size of each of the included studies, and then these are assigned different weights based on the quality of the study, the number of the size of the sample, and from that you estimate a summary estimate of effect with a confidence interval, and you'll see that in a forest plot shortly. Finally, you've got to assess a consistency of the effect across the included studies. This is defined as heterogeneity. So whether or not all of these studies are using the same kind of template, in a sense. Is it maybe there's something else that's affecting it? So an example would be if one study was looking at only males with type B dissections, and another study was looking at only females with type B dissections. If you weren't and there was in fact truly a difference in these people, which is quite actually true in reality, you would end up with different estimate of effects within these studies, and your software that you use for the meta-analysis will capture this as heterogeneity. So if your heterogeneity is too high, based on either a Cochrane's Q on a chi-squared test or an I-squared, you need to use what's called a random effects model if it's too high, because there's too much randomness in the study. It reduces the quality of your results, but it doesn't make it less applicable. If the heterogeneity is low, you can use a fixed effects model, because that means what you're targeting is actually having an effect on the result. That's the best way to summarize a fixed effects model. What's your that question you're targeting, that variable, truly has an effect. I'm going to summarize some different tools that are used to describe the effects measures. So you may have heard of relative risk, odds ratio, risk difference, and number needed to treat. Some of them are quite similar, but their role can be different. So relative risk is the risk compared between groups. So risk is technically the event rate between 0 and 1. It's like the probability. So I'm just going to say this directly. Relative risk is a risk of the outcome in the intervention group divided by the risk of the outcome in the control group. Now, in order to assess its relevance clinically, you need to know what baseline risk is. And this is often something you don't have when you're doing a meta-analysis. So relative risk can be a little bit difficult to use in a meta-analysis. Now, odds are a bit challenging also to understand. The best people to ask about odds are actually gamblers. Now, this looks at the probability of a particular event to occur divided by the probability that it will not occur. So if you were to create a row where you've got event 0, event 1, say dead or alive, and then a total. If you were to have 30 people in the dead, 70 in the alive, that means you've got 100 people in total. Risk, relative risk is 30 divided by 100 divided by 70 divided by 100 in brackets, because you're looking at the risk. So the risk of being dead is 0.3 or 30%. Odds, however, are different. Odds are comparisons without the total, so it's 30 to 70. It is the best descriptor in our form of statistics, but it can be very hard to kind of gauge how it applies to real practice. And that's why you need to use things such as risk difference or number needed to treat when describing your findings. You don't use it in your analysis, but in your discussion, that's what you want to be talking about. Risk difference is basically just absolute risk reduction between treatment and control groups. And number needed to treat is a number of patients that needs to have the intervention to prevent a single event. There's different places that often tell you different values as what you need to strive for. But this is number needed to treat is really what you want to be able to target and state. So with Mr. VG, the number needed to treat will tell you that, say, 10 people need to have an early TEVAR for one aorta-related death to be avoided in a 1-year follow-up period. That's an example of what a number needed to treat would state. And that's very easy to tell your patients and explain to them why you want to be doing an intervention. You can say, if we do this, out of 5 people that we do this for, we'll be able to prevent 1 death. If we don't do it, if we do it in a late period, maybe it'll be 10. These are things that people understand much easier. This is a forest plot exactly for the question that we're asking. So on the top, I believe that is 30-day complications. And underneath, I believe there's 1-year aorta-related events. So things that you can clearly see here are an odds ratio was used. Here, I'll come in here. An odds ratio was used. A fixed effects model was used. And 95% confidence interval was used. I'll explain what that is shortly. So I've broken this up into studies that included hyperacute and those that excluded hyperacute. So these are studies that said the intervention was done in the first 2 days. That's considered hyperacute. And so when you include hyperacute in the top here, you can see that there's a favoring of late intervention when it comes to any complications in the 30-day period. I think that's what it was. If you exclude hyperacute, the conglomerate subtotal here actually crosses this line in the middle. So the 95% confidence interval is from 0.8 to 21, which means that you cannot reject the null hypothesis. You can't reject the null hypothesis here. When you exclude the hyperacute, this technically means that there's no statistically significant difference between intervening early and intervening late when it comes to any type of complication in a 30-day period. Here's underneath is a much more solid one where it clearly shows that early intervention in the 1-year follow-up significantly reduces aorta-related events. So if you look at the odds ratio here, what's important is if the 95% confidence interval crosses the middle, which is 1 in odds ratios, it means you can't reject the null hypothesis. You can also see some studies for heterogeneity at the bottom here. For instance, right there, you've got your I-squared, which is 0%, which means we can take a fixed effects model. And here at 15%, which also means you can take a fixed effects model. 0 to 40% means there's probably no heterogeneity. 30 to 60% means there's probably moderate or some heterogeneity. So once you start getting above 30%, you need to think, we should probably use a random effects model. As you can see here, specifically for hyperacute, there is actually some heterogeneity, but I elected to use a fixed effects model here because of the fact that across subgroups and total events, it's actually relatively low heterogeneity. If you're only doing this, you should probably use a random effects model. This is a funnel plot. This is also another descriptor of heterogeneity. You want all of your studies to fit within this 95% confidence interval margin. I haven't actually seen too many cases where they've sat outside, but you should include this in your the meta-analysis. Now that that's all done, very quickly touching on narrative reviews. So as I said earlier, they're basically like systematic reviews, but they don't have the reproducibility, and you don't need to just crunch numbers like a maniac. They can help target your topic if what you've the question you're asking is not broadly researched. So if there's only a few niche studies, you can't do a formal systematic review, or you're unable to properly find any studies in your niche topic, you want to do a narrative review. Do a systematic review first for something that's slightly broader, and then use that finding to try help explain your question in the narrative review. With a narrative review, it helps you to guide the development of primary studies or identify missing space in research. It's a bit of a cliche in research for the conclusion to say this opens up exciting and myriad opportunities for extended research to help answer this topic. It's a cliche for a reason. Narrative reviews are lower level research because they are very highly biased, because you're just on Google Scholar or Google searching things yourself. But they are very, very important. So again, for this question with Mr. VG, a narrative review, for instance, could be, and will be because we're working on it, is answering the question of, is there a subgroup of patients with uncomplicated type B aortic dissections that would benefit with early intervention? So this means I need to go into the physiology of type B dissections, patient characteristics, what is uncomplicated, the benefits of early intervention, and kind of put these all together. There's no system to it. It's just a uni project, basically. Primary studies are not that different from systematic reviews. Very strict methodology. I was once told that a reader should be able to understand your entire study, nearly down to the results, just by reading the methods. Since then, when I've been doing reviewing anything, any paper, I skip straight to the methods after reading the abstract to see if I'm interested. Your methods need to include categories such as patient identification, selection, data collection, and how you store the data, very important, statistical analysis, and ethics. I'll briefly touch on ethics shortly. Results should be broken down, so put them into subcategories, and stated. No comparisons. You're simply stating your results. You're not coming to any conclusion. Your first thing needs to be descriptive, so the number of participants you had, gender distribution, age, and any statistics that answer your research question need to come afterwards, and try break these down into subcategories. You shouldn't be really stating p-values in your discussion. We'll go into p-values later. That's everyone's favorite thing. But you need to compare your results within the study and to previously published data. Don't be stating new results. And always discuss limitations. It's easy to include a limitation where you say your study type isn't high level enough, if you're doing a case control, for instance. And you can state how it could be high level or whether or not it even can be. Sometimes you can't do a randomized control trial. It's simply unethical to do a randomized control trial. So you can state that and discuss that. You should always include your limitations. Statistical analysis in your primary study. This is an example of the stats that I've done in a paper I've completed but not yet submitted. So on the left are your descriptives. So age, how many males we had, the comorbidities, antiplatelet use, cause of death, etc. And on the right is a time to event assessment, which is a Kaplan-Meier survival curve. So these are like things that are included specifically in the results. You don't want to include these in the discussion. If you're stating new numbers or graphs in the discussion, you've got it all wrong. Ethics is a minefield. This is Regis, and like anything the government makes online, it's terrible, crashes, and rarely ever works. But when you create a study, you get 3 numbers. You get your project ID, you get your, which is here, you get your ethics number, which is just, it starts with ETH, and then you get your site-specific ethics. Now, if you're doing it on multiple sites, then you need multiple site-specific ethics. Though it's really, really straightforward to get once you get your first ethics, and it can be so tedious. It can take months and months. So if you're going to start a research project and you say, I'm going to finish this in 3 months, and you need ethics, it's not getting finished in 3 months. You might get the ethics in 3 months. So think long term. I have not included I may not have included a summary of some of the tools that you need to use when doing all of this, but I'll get to that right at the end. Maybe it's at the end. Biostats is challenging. So biostats, let's start by breaking it up into types of data. You've got quantitative, countable data, and you've got your categorical, qualitative data, which can still be numbers. So with quantitative, you've got discrete whole numbers, such as gravity parity, and you've got continuous, which can be an uninterrupted range, such as weight. Often, some people get confused by this. So, for instance, if you were to say age, why can't age be discrete if you're not including including decimal points? This I'm not sure if there's a definitive answer to this, but if it can sit on a ruler, then it's continuous. If it can't sit on a ruler, because you can't have half a baby, well, you can probably, but you can't actually have half a baby, that becomes discrete. Categorical is actually quite fun. There's no numerical quality, though they may actually. So an example is a Likert scale in an ordinal, which means you've got ordered categories, 1 to 5. It's limited there. You aren't, for instance, with quantitative data, discrete ones, you technically aren't limited as to how many babies you can have. With Likert scales, you are. The faces pain scale is another example of that, slightly less numerical. Nominal is similar to ordinal, but there's no actual order to it. Consider that just like blobs in space. The last one is dichotomous, which is binary, yes or no, dead or alive, 0 or 1. And so there's these 5 types of data points or variables that you need to consider. And this affects the way you can do your maths. Descriptive statistics. There's a lot of errors can be picked up. So random systematic and sampling errors can be picked up, particularly quite early on. With categorical variables, you want to create a table of frequencies. They can be two-way frequency tables, bar charts with like different subgroups if you want to. And often these will require non-parametric tests depending on the way that things are arranged. Quantitative variables, so if you remember, this is going to be your continuous, for instance, or discrete. You need to check the distribution of these. Now, there's a few ways you can do this. Some people like to use the skew or kurtosis number. Others like to just visualize the histogram, which is the diagram on the right. But the one I like to use, which I haven't included here, is actually the QQ plot. Most software packages actually let you create a QQ plot to see if it's linearly increasing. So the histogram will demonstrate your mean with standard deviations, if it is in fact normally distributed like a clean bell curve, if you've got some form of skew, which is demonstrated at the bottom there, you want to use your median and interquartile range. You can see how median and mean will shift positions based on the skew of it. The way I like to say, if someone says something's right skewed, it means its tail is on the right. If something is left skewed, its tail is on the left. Right is positive. That's sort of intuitive for some reason, saying right is positive. But that's simply how it is. And you'll find that your skew value is also positive. Normally distributed, your skew should be 0. Now, confidence intervals, going into this is a bit challenging, as you need to understand the concept of the central limit theorem. So if you include enough random variables within a sample population, its distribution will lean itself towards a distribution of the population. Sort of intuitive yet again. The more you include, the more it'll reflect the population. But we'll touch on central limit theorem a bit more. There's another definition, is the standard error of mean. So that is how far the sample's mean is from the population mean. If you've got a larger sample, you're likely to have less of an error or standard error of mean. Now, the confidence interval is simply, as it states, your confidence that any random result within your sample will fit in a percentage of the broader population. So when you say 95% confidence interval, you're literally saying that I am 95% sure that when you take this number, it will fit within the population, within the 95% distribution of that population. Often you don't actually know the standard deviation of the population itself. That's when a student's t-distribution is performed. So when someone says a student's t-test, that's what you're looking at. To do that, there's some fancy maths that was invented some time ago, which considers the degrees of freedom, which means basically how things can be connected to one another, how each participant or each included person within the sample can be connected to one another. So for instance, if you're doing a single t-test of some sort and there's 50 people included, there's actually 49 degrees of freedom. It will usually be n-1 because you can't, the first person can't be connected to themselves. So if it's like, for instance, 2 people, there's 1 connection. This is a little bit fun if we're talking about p-values and why p-values are actually sort of useless. We can look at the strength of evidence. So formulating a null hypothesis can be a bit challenging. So I'm presenting here a question. Does drinking 1 to 2 glasses of wine every night reduce cardiovascular risk? That's your question. The null hypothesis is not that. Your null hypothesis is cardiovascular risk will not change whether you drink 1 to 2 glasses of wine every night or if you completely teetotal. So that's your null hypothesis. Your p-value, what does it mean? So it means that it can mean one of 2 things. So the first thing it means is the null hypothesis is in fact true as happened by remote chance. So if your p-value is equal to 0.05, it means that the null hypothesis might be true, but there was only a 5% chance of it actually happening. What's usually taken is that the null hypothesis is in fact not true, and it can be rejected for the alternative, which states that there is in fact an effect. If a null value exists outside of that 95% confidence interval, then the evidence of effect is considered p is less than 0.05, which is usually what you're aiming for. Doesn't always mean it's important. So the diagram on the right shows your importance threshold for a value. So if you have a effect mean of say 10, okay, I'll give you an example. Does an ACE inhibitor reduce your blood pressure more than a diuretic? If your effect mean is 10 millimeters of mercury, that an ACE inhibitor drops it by more than 10 millimeters of mercury. But most studies say that 8 millimeters of mercury is anything more than 8 millimeters of mercury is relevant. That will usually mean that you've got a p-value that's less than 0.05. If in your confidence interval you're finding that the lower end of your 95% is less than 8 millimeters of mercury, but your higher end is way above, say it goes 6 to 14, so mean being 10, you end up with this one here, possibly important. The mean crosses the importance threshold and is above it, but your standard deviation means that it's below, which means it's possibly important, not necessarily. If your standard deviation passes across a null hypothesis using the odds ratios, for instance, then it means it's you can see here that if the top end of the 95% confidence interval is below the importance threshold, then it's a true negative. But it goes above it, then you've got something wrong with your study. Now, different t-tests and when to use them. We might be going a bit over time here, but I'll try and bust through it. So a one sample t-test means that you're comparing a sample's mean to a known population mean and standard deviation. So you've got one sample and you've got the population. It's often quite difficult to do. If you do know the population standard deviation, then you can do a z-test. But if you don't, you need a one sample t-test and use a student's t-distribution. I'll go into binomial tests in a little bit. A paired t-test means you've got a single character and you've got two scores linking them. So here I've written down the null hypothesis that there is no difference in the three-pointer count of Steph Curry before and after his Under Armour sponsorship. This is probably going to come up true. A more appropriate example in medicine would be a null hypothesis again. A patient's mean blood pressure will not decrease after they commence diuretics. So you've got a variable before the intervention and one after. So it's paired. You've got one character and you've got the two means that are paired. So the degrees of freedom for this is n-1. You create a point estimate, which is the best estimate of a population mean. An independent t-test. Now, you don't have that central character, but you're recording the same type of score. So remember in the previous one, we're recording two different types of scores. Another null hypothesis. There is no difference in the rebound count of Lakers players compared to Pelicans players in the first game back in the season. So it's the same score that's assessed, which is the mean rebound count, but you've got different characters. You've got Lakers players and Pelicans players. So that becomes independent. They're independent of each other. So degrees of freedom is n minus the number of characters that are actually measured. An assumption is made that the variability in the two groups is in fact the same. Now, proportions. Binomial data often requires proportion. So binomial, remember, is 0 and 1, yes or no. One moment. Might have to sneeze. I've had my COVID vaccines. It's okay. So here, what you can do is present these as confidence intervals. If anyone can be either type A or type B, if you're going to randomly select someone from the population, their probability of being type A represents a proportion of type A. So this is them representing the whole population. It's not an odd. It's not odds that we're talking about. In a one sample hypothesis test, so you've got a single sample, you use a binomial test. And again, you're assuming for normal distribution. This is a little hard to gauge, so I created an explanation here. So say a game of chance was played, but you're flipping a coin, and you flip it 256 times. You would expect that 128 would be heads or tails. You do it in practice, and you find that 156 were heads. So you would need to do a binomial test to assess whether there's an unfair coin toss. You've got a single sample here. You're not comparing between different groups. So if you were to do this using two different types of coins, you can't do a one sample test. So you can't do the binomial test. When you're comparing paired proportions, that's when you start using McNemar's test. So it's a special case of the chi-squared, which I'll go into, but you need to create a 2 by 2 contingency table with dichotomous traits. So an example here is a researcher wants to see if a Nike shoe has an effect on injuries in the season for basketball. So is someone injured or not? I wrote that really poorly, apologies. So another thing you can do is a population is tested before the drug is given, positive and negative for a disease, and after the drug is given, positive and negative for the disease. So whether or not it cancels out or not. And you need to do a 2 by 2 table. The chi-squared looks at independent proportions. Now in the McNemar's test, they're actually linked. So a question you can ask again here is, a researcher wants to see whether or not the rates of depression in doctors differs between those doing physician training and those doing surgical training. I believe probably it's higher in surgery, but we won't go into that. So let's briefly touch on this. In the McNemar's test, you've got the drug being given to one person, so it's paired. You've got pairing. In chi-squared, it's separate groups which can't actually mingle because you technically can't go from surgical training to physician training. You can, but this isn't something that's being assessed. It's just a cross-section. So they're independent proportions. It's only useful if none of the proportions are that small. If that happens, you can do a Yates continuity correction, which bumps everything up a little bit and allows you to compare the proportions, just increases it. And you can do a Fisher exact test as well, I believe, if your numbers are literally above 5. Below 5, sorry. Association. The actual chi-squared result is useless unless there's an association and a confidence interval. So when doing a cross-sectional study, just looking straight down the middle to see the proportions, you need to just simply do a difference in proportions. So you calculate the difference and the standard error for 95% confidence interval. And does your difference in proportions cross 0? If it does, you accept the null hypothesis. So remember the 95% confidence interval. If it's crossing 0, the 0 is in the middle there, accept the null hypothesis. A cohort study, you want to look at risk difference or relative risk. So the cohort studies look at the proportion of individuals who have developed something over time. So the risk of getting cancer, for instance. It's similar to differences in proportions, but this time you want to ask, does it cross 1? Again, with the 95% confidence interval, you always want to be using that. Just because your relative risk might be 1.5, you can't reject the null hypothesis just with that. If your 95% confidence interval is going from 0.8 to 1.9 with your actual relative risk in the middle, you can't reject the null hypothesis. Finally, case control studies, you want to use an odds ratio. So you can't actually calculate the risk of as participants have already had the effect. So there's no time to this. They either have it or they don't. This is really good when you've got rare diseases. You can't just wait for a rare disease to happen. Well, you can, but it's unreasonable to do so. This is when you get a bunch of people who have it, a bunch of people who don't have it, and then compare the risk factors. You can create a 2x2 contingency table again for the odds of exposure leading to an effect. So an example here is, let's consider mesothelioma as a slightly rarer condition. The odds of asbestos exposure leading to mesothelioma. So you get a bunch of people with mesothelioma, you get a bunch of people without. You look at how many were exposed to asbestos, how many weren't exposed to asbestos. So you've got yes or no for both of these. Create a 2x2 table with the number of people in each of these, and then you do an odds ratio. And again, does it cross 1 while looking at the 95% confidence interval? Very quickly, non-parametric tests. So you can see the QQ plots there, which are that linear line and the curved line, or the sigmoid curve. Now, you can see here with the with this histogram, there's some linearity to the QQ plot. Here, it's heavily right skewed or positive skewed. So you can see how the QQ plot doesn't match up. Down here, you can't figure out what's going on here. Right, so you would do a QQ plot and see that there's actually a sigmoid curve. So everything on the right here does not have an appropriate bell curve to it. They're skewed in some way. If this happens, you need to perform a non-parametric test. So what this does is when you're doing the maths, you aren't actually looking at the numbers themselves, you're looking at the ranking of the numbers. So instead of things being going exponentially or sigmoid curve like this, you just look at how do things rank between each other, the relative order of them, and that's how the math is done. It is less ideal, not particularly good, but sometimes you have to do it if you're not willing to adjust the data. So for instance, with this one here on the top right, you could technically do a logarithmic shift for all of the data points and get a straight QQ plot, but sometimes it's not worth it, particularly for the lower one here, for instance. With dichotomous values, the 0 ones, you can use a binomial or sign test. First one I want to talk about very quickly is a Wilcoxon ranked test. This is a non-parametric analog for the paired t-test. So again, let's have a look. There is no difference in the 3-point account of Steph Curry before and after his Under Armour sponsorship. If you were to find that the curve actually went up and down like this, then you would have to use Wilcoxon ranked. The Mann-Whitney U test, non-parametric analog for the independent t-test. So there's multiple, you don't have an individual character, you're using the same score for 2 different characters. They compare continuous values between 2 groups, and this is a Mann-Whitney U test. So it tests whether or not the null hypothesis has a median of the 2 populations being equal. So remember, with non-parametric, which means standard distribution is incorrect, you can't use mean. You need to use median and interquartile range. Nearly done here. The last thing I'm going to go over is power and sample size. Power is the probability of finding an effect when it truly does exist. Usually you want to aim for 0.8 or 0.9. It's the opposite of type 2 error, which is false negatives. If you do a pilot study, or you've already got population of standard deviations, you need to assess what the sample size needs to be when you're creating a primary study. And you can do this using power and sample size calculations. The size of the minimum actual effective importance for detection needs to be done. So if, for instance, you're doing ACE inhibitors and diuretics, and you want to get a minimum blood pressure difference of 8, that's what it would be. The two-sided significance level, you usually want that to be 0.05, so that's your p-value. And the power, you usually want 0.8 or 0.9. The sampling variability looks at the standard deviation of a population that you know. So often you need to do a pilot study to figure out roughly what is a population, the standard deviation of the sample or population, and then you can roughly get the sample size to aim for the result that you want. So we won't go into all of this complexity down here, and we can probably skip Cohen's d as well. There's a little bit more. Linear regression. So this is where you want to look at a correlation between two continuous variables. Say you've got a massive data set and you want to see, is there a correlation between bone mineral density and age, or BMI. These are continuous variables. The bone mineral density of the hips and your age, both continuous variables. You can do various correlation stats. One's a Pearson's correlation coefficient, looking at the linear association between these two variables. If you get a negative value, it means that as one value increases, the other decreases. So as your age increases, your bone mineral density of the hip decreases. This assumes normal distribution. A Spearman rank correlation is basically the non-parametric form of the Pearson correlation. So you assume nonlinearity, and it handles ordinal data much better. The regression equation is just a simple linear equation. Regression is linear stats. So in y equals a plus bx, we won't use alpha or beta, your intercept is a, which means the value of y when x is 0, and your slope is your beta. So an example is like this. If you're doing bone mineral density and age, technically at the age of 0, your intercept is the bone mineral density there at the age of 0. Then with every year you go on, slope, which is b, is how much that increases, like that, or decreases, like that. Finally, you can use R squared, which is the proportion of total variability explained specifically by this regression model. The higher it is, the more it means that those two variables correlate exactly with each other. And a multivariable model can be done. Many of you may have heard of ANOVA, which is a one-way analysis of variance. You can compare the mean between different groups. And then, unfortunately, you can't actually see the statistical difference between these groups because it's an omnibus test. All you know is that there is a difference. So you need to do a post hoc test, such as a Bonferroni or a Tuckey's test. And all of them have their own benefits, which we can't get into now. When doing multivariable models, if you've got continuous data, you want to do a multivariable linear regression. That's like the equivalent of an independent samples t-test, but with multiple variables. If you've got binary data, you'd be doing a chi-squared test, right, for independent binary data. And for that, you can do logistic regression. Finally, time to event, such as that Kaplan-Meier graph I showed you, you can do a Cox proportional hazards model, which I won't go into here. Yes, I have included the software needed. So if you want to do a search strategy, you want to be using Ovid. I guess you can use PubMed, but I've always used Ovid, and you want to include Medline, Embase, and Cochrane. Source management, I use EndNote, and I have used Zotero. Both of them have great implementation in Microsoft Word. I haven't used Mendeley, but I've heard it's brilliant, and it's all online as well. To do a meta-analysis, you want to use a free RevMan software that Cochrane gives out. You can also do it with RStudio, but you've got to learn coding a little bit. Data analysis itself can be done with my favorite, which is SPSS. Heaps of people hate it, but you can use RStudio, MATLAB if you've truly lost your mind, or Prism, GraphPad Prism. If you don't use Excel, you can use Excel for like basic stuff just to get descriptive stats, but just don't use Excel. Finally, for drafting documents, use Word. Some people like to use LaTeX if you're truly in the programming world, but Word is best because you can send to someone else and everyone has Word. EndNote has great implementation as well. If someone likes to use LaTeX and wants to be able to do source management, you can ask me privately, and I know great tricks on how to do it, but just stick with Word. Finally, a summary. Identify a question, formulate a literature review, first as a big systematic review, and then answer your niche question using a narrative review to help then guide you into your primary study. And in your primary study, you'll have to use all of these biostatistics I explained. I'll stay on for a little bit longer for any questions. Obviously, you can catch me privately as well. And I probably will be posting more videos on here, so please subscribe as well to my YouTube channel. But if you've got more questions, Vincent and I will be on the line, and we'll probably leave in 10 minutes or so if questions aren't flooding in. But yep, I hope you enjoyed. I hope to do more of these. At Royal North Shore, we're actually looking at some medical students to help get involved with some of our research projects. So if you're interested, please just shoot me a line. And if you want guidance on research, I'm more than happy to guide you. I hope in the future that I could create a small community where we can discuss our research projects, help get guidance, and give some recommendations and support on how to go ahead with research, because it can be a very scary domain. So any questions, go ask ahead. I'll be on the line.
Okay. One question. Do you have recommended results for learning how to do data analysis?
Now that's really tough. I
That's from
learned,
Jane.
I learned, Jane, I learned most of my data analysis by trial and error on SPSS, and then finally coming to terms with how to do it. I can send you some notes from a biostats course I've been doing. That can be helpful. Otherwise, I personally don't have sources that I've used. Google has been amazing. Um, don't go to Wikipedia.
No question.
Yeah,
Any good
Jane. Yeah,
resource?
I'll send you the biostats stuff privately if you get in contact with me. Dilnor has asked, are there any good resources for correct methodology? Actually, before getting on to that, Vincent, are there any resources you've used for data analysis?
Data analysis. Let me. It really depends on like how interactive you want it, what your learning style is. Like
Mm-hmm.
you can just literally just read resources. Like the company behind Prism has like their own website, like kind
Oh
of
yeah,
teaching statistics and pitfalls
yeah.
and things.
Prism
But
has a really good one. Yeah, I know that.
but obviously I would imagine a lot of universities have courses
Mm-hmm.
on biostatistics.
Yeah,
That's what Erin has done.
yeah,
You could also just talk to um statistics department. So I think UNSW is Stats Central. I'm
yeah.
not sure how they might have courses. I'll need to check my emails that like they run courses throughout the year.
Mm-hmm.
Um, but that's another resource.
You can also just learn via osmosis by being part of research groups, coming to
Uh,
them with questions and then saying, how would I study this? Find relationships and discuss it. I might
um,
just move on. Um,
yeah.
any good resources for correct methodology and research? Yes.
Research.
The Equator Network has great criteria on how to go ahead with research and the criteria you should use. It's got very bullet pointy. These are the things you need to hit, particularly for systematic reviews and a lot of primary studies as well. So you want to go to the Equator Network. Hayden has asked, Vinny, help with this one as well. I'm trying to determine if a patient demographic is significant so it can be placed in a multivariable logistic regression. Would you suggest using ANOVA for variables with multiple criteria? So there's two ways. Yeah.
I'm gonna. Sorry. What were you gonna say?
I'm going to say there's two ways of approaching this. One way would be to target a certain question. So, for instance, I'll give you an example: surgical post-op 30-day readmissions based on anesthetic status. So, were they general or local / sedation? For instance, you could just compare these directly. First, assess is it normal distribution for each of these. Actually, that wouldn't be ideal. Let's say total time anesthetized and the average discharge time or discharge from ICU time, days in ICU. All right, days in ICU and time anesthetized. You would probably want to first do a Mann-Whitney U, as you've said, if it's not normally distributed. But if you've got many other variables, I would do an ANOVA with a post hoc analysis for non-parametric data to see is anything else having an effect. If it isn't having an effect, then you can say that anesthetic status is independently having a effect on the final outcome. Does that make sense? So first run your one-to-one like Mann-Whitney U, see if there is a significance, then run an ANOVA for non-parametric, with your post-hoc analysis being non-parametric, and then determine whether or not it is the only thing having an effect. If it's not the only thing having an effect, then you can start tailoring your answer to say that all of these variables are having an effect on the outcome of your question. If your Manwick-Niu comes up with a really bad p-value, then there's no point doing an ANOVA. Does it make sense? Okay, great. Vinny, did that make sense? Thought I was blabbering a little bit.
Okay, it makes sense now. I'll just add, it like this might need a bit more consultation in person or one-to-one in terms of what the actual research question is,
Yeah,
because I
you'd
can't
need
quite understand.
you need a research question, and it would be good to look at what the data is, the variable types and stuff like that. But in
Just
the
in
end,
terms
yeah,
of
yeah.
just in terms of the stats, I would say so. You would use an ANOVA to say, we want local versus general, and we're measuring a, a quantitative variable. So, like, say, how long did each group stay in ICU for each different group? If it's not normal, the actual non-parametric version of an ANOVA is called the Kruskal-Wallis test, and then you would do your post-hoc test with a variety of corrections. There's different types. Yeah, and if the Kruskal-Wallis test doesn't show any significance, there's no point doing any post-hoc or the multivariable logistic
So that's the omnibus test
regression.
result of the Kruskal-Wallis. If that doesn't show significance, no need to do further post hocs, right?
Yeah. There's only 17 left.
It's okay. I'll stay on for a little longer.
Yeah. Maybe till 5 past or something, then we'll call it.
Yeah, that's fair. I feel like the last 15 are probably zoned out, watching something else, muted it. Unfortunately, you can't put this on 1.5 time or 2 time.
Patrick set up before post bench. I don't know if that means anything.
Oh, that's Pat. He's my friend. He's telling me to mention my maximum bench press.
Oh, okay, that's what it means. And Tom Sniggles BC equilibrium
Don't worry
equation
about
dot
that.
PDF.
Don't worry about that. That's a meme.
People are dropping.
Yeah, that's good. All right, Vinny. I think I'm going to throw in the towel for this one. My my on-call from the other night has caught up with me, and the tea and coffee from the day is wearing out. So, if anyone's left on, thank you, and hopefully next time we can discuss research. Thanks, Vincent.